In this lecture video, I will discuss a case of a stroke in young, that is rare conundrum. Miss Baisali, a 22-year-old right-handed female resident of Haryana and a MBBS final year student, came with presenting complaints of intermittent bluish discoloration of her fingers of both hands and perioral area since 4 years. She had also complained of easy fatigability, which increases on exertions since 4 years. She visited local physicians for her symptoms. She underwent regular checkups along with chest x-ray, but nothing conclusive came. She was still having fatigability with bluish discolorations of her finger and perioral area with SpO2 of 78% on room air. This bluish discoloration was not cold to touch with no seasonal variations noted. She used to manage her routine activity of daily living in this state of health since 4 years. In the afternoon of 5th of December 2014, she developed sudden onset of tingling and numbness of her both hands up to the wrist and perioral area with associated slurring of speech. She was completely aphagic for about 5 minutes following the events. However, she could comprehend well during the event. These symptoms lasted for about 15 minutes with complete resolutions of her symptoms. She did not complain of any weakness in any limbs, any facial asymmetry, blurring of visions, abnormal movements of limbs, loss of consciousness during the events. This was the NCCT brain, which was done on 5th of December 2014, which shows hypodense area in the right vessel ganglions. And MRI brain done on 7th of December showed acute and chronic infarct in the right gangliocapsular region. We retrospectively took the history of her easy fatigability on exertion. She noticed becoming dyspneic while climbing stairs and lagged behind her colleagues. It was insidious in onset and non-progressive. It was not associated with cough or sputum. It does not aggravate during winters or early morning hours on exposure to dust, pollens, with no diurnal variations or positional variations of her symptoms noted. It aggravates on physical exertion and relieved upon taking rest. There was no history of chest pain, syncopal attacks, swelling of legs, facial swellings, decreased urine output, pain abdomen, yellowish discolorations of eyes or abdominal distension, or any sudden onset of loss of weight, joint pain, skin rash, or fever noted in her history. The past history was not significant. There was no history of similar illness. Personal history: she consumes mixed diet with normal sleep and appetites, with normal bowel and bladder habits, with no history of any substance abuse. Family history was not significant, with no similar complaints in the family. No history of tuberculosis, pneumonia, asthma, heart disease, or hypertension in the family. Medical history was not significant for this patient. So, with this history, what differential you will consider at this point of time? This patient is having dyspnea on exertion, central cyanosis, and TIA. Let us discuss the first slide first. This final year student had intermittent bluish discolorations of her fingers as well as on the perioral area since 4 years. This could likely be a central cyanosis because in central cyanosis, perioral area, that are mucous membranes, are affected along with the fingers. She has a complaint of fatigability, that is easily getting fatigued, and increases on exertion since 4 years. Means she has cyanosis that likely to be central with easy fatigability which increases on exertions since 4 years. She visited the physicians and regular health checkup were done with chest x-ray because of fatigabilities, easy fatigabilities, that is dyspnea on exertions, but nothing came. She was still having bluish discolorations of fingers along with perioral areas with SpO2 of 78% on room air. These bluish discolorations were not cold to touch because these were not cold one, means along with no seasonal variations noted. This history signifies that it is likely to be a central cyanosis because in peripheral cyanosis, the bluish discolorations are cold to touch and during winter seasons it get aggravated. With this history, we can conclude that the patient is having central cyanosis. However, this patient used to manage her routine activity of daily living in this state of health since 4 years. Means he used to manage her activities with this SpO2 of 78% since 4 years. But in the afternoon of 5th of December 2014, she developed tingling and numbness of her both hands up to the wrist and perioral area with associated slurring of speech. This lasted for about 5 minutes and with the resolution of her symptoms within 15 minutes of the onset. However, she could comprehend well during the event. During the events, there was no history of weakness of any limbs, any facial asymmetry, blurring of vision, abnormal movements of any limbs or loss of consciousness was noted. Thus, these events signifies that the patient had TIA on 5th of December, a cerebrovascular accident, CVA. This was the NCCT brain which was done on 5th of December, which shows hypodense area in the right basal ganglion, which again signifies that there was an infarct in the right basal ganglionic regions. MRI brain which was done on 7th of December shows acute on chronic infarct in the right gangliocapsular region. This was the infarct in the gangliocapsular region, which again suggests that this patient had stroke on 5th of December. We took the history of her easy fatigability on exertion and she was dyspneic while climbing the stairs and lagged behind her colleagues. With no cough or a sputum during her this exertional fatigability, it does not aggravate in the winter seasons or early morning. No dust or pollen exposure could aggravate the symptoms. No diurnal or positional variations noted. Means this signifies is that the patient had shortness of breath. And this shortness of breath aggravate on physical exertion and relieved upon taking rest. These were the negative history. No history of chest pain, ruled out cardiac cause of the shortness of breath. No history of syncopal attacks, ruled out the again the cardiac cause, swelling of legs with the cardiac cause, facial swelling, ruled out the renal cause, decreased urine output in the renal cause is ruled out. Pain abdomen, any GIT problems, Eloise discolorations, any liver issues was ruled out. No history of sudden weight loss, ruled out. The malignancies, joint pain and rashes, ruled out. Some inflammatory disorders like SLE and the fevers, chronic fever infections. The past history, personal history, family history and medical history were not significant. So, this patient had dyspnea on exertion, that is shortness of breath, central cyanosis and history of TIA. What differential you will consider with these three positive symptoms that the patient presented? So, the differential that we should consider with these three positive symptoms, that is shortness of breath, central cyanosis and TIA, include ventricular septal defect, contraction of aorta, teratology of Fallot, total anomalous pulmonary venous drainage, hypoplastic left heart syndrome, pulmonary vein stenosis, persistent foramen ovale and pulmonary arteriovenous fistula. These all conditions can lead to shortness of breath, central cyanosis and TIA can occur. TIA in VSD is because of the reversal of shunt leading followed by paradoxical embolism, teratology of Fallots. These all can lead to paradoxical embolisms from left heart, the embolus from the right ventricles goes to the left ventricles followed by losing into the systemic circulations. These hypoplastic left heart ventricles will lead to TIA because of hypoperfusions into the systemic circulations because of the low ejection fractions. This pulmonary stenosis will also cause TIA by hypoperfusion as one of the mechanism of TIA. Persistent foramen ovale with the reversal of shunt with paradoxical embolisms and pulmonary arteriovenous fistula will also lead to TIA by paradoxical embolism. So, with the history of shortness of breath, central cyanosis and TIA, our differential, this could be our differential diagnosis. So, still we cannot conclude that what could be the diagnosis with these three symptomatologies that the patient had presented. On examination, my patient was conscious, cooperative and well-oriented to time, place and person. Weight was 55 and height 172 with BMI of 18.6. Here, cyanosis and clubbing were present in my patient. Here we can see the cyanosis, bluish area along with clubbing can also be seen in this patient. Here we can see that the clubbing to be present in this patient. Pulse was 90 per minute, regular in rhythm, normal in character and volume, with no visual wall thickening, radioradial, radiofemoral delay, and all peripheral pulses were failed. BP was normal in all the four limbs in supine and in standing positions after 3 minutes. Respiratory rate was 20 breaths per minute and was abdominothoracic. GBP was not raised and no distended veins were seen in the neck and chest. Now, our another positive findings was included, that was clubbing after we have done a general examination of the patient, with another positive findings along with dyspnea on exertion, central cyanosis and TIA. What could be the differentials that we should include or exclude that we have discussed earlier? Now, we have included clubbing along with TIA, central cyanosis and shortness of breath. And here we can see that these clubbings are the features of all of the following differentials that we have discussed, that is ventricular septal defect, correct action of aorta, tetralogy of Fallot, total anomalous pulmonary venous drainage, hypoplastic left ventricle, pulmonary vein stenosis, persistent foramen ovale, and pulmonary arteriovenous fistula. In all of the differentials, clubbing will be present. Still, we are not sure what will be our diagnosis. Let's proceed further. CNS examination was normal at the time of examination. Higher mental function was normal. Cranial nerves were normal. Motor examinations with tone normal and power 5/5 in all the four limbs. Reflexes DTR was 2+, and plantar bilateral flexors. Sensory examinations and cerebellar examination were normal. Meningeal signs were absent. CVS examination was also normal, with neck veins not engorged, shape of the precordium normal, apex weight in the fifth intercostal space, left side, medial to the mid-clavicular line. There was no abnormal pulsation seen or felt, no palpable heart sounds noted. S1, S2 was heard with no murmur was heard in areas. Here we saw that the cerebrovascular system, cardiovascular system is normal. Now, what differentials you will consider at this point of time after we have concluded that CVS examination is normal? So, apart from dyspnea on exertion, central cyanosis, TIA, clubbing, this patient had CVS examination being normal. Will you include any differentials or exclude the differentials after we have done the CVS examination? Here we can see that in CVS examination, all of the differentials will have a murmur in any area, like in ventricular septal defect, there will be hollow systolic murmur at the left sternal border. Contraction of aorta will have systolic ejection murmur in the back below the left shoulders. Tetralogy of Fallot will have systolic ejection murmur of pulmonary stenosis and holosystolic murmur or VSD. Total anomalous pulmonary venous drainage will have systolic ejection murmur at the left sternal border with prominent second heart sound. And hypoplastic left ventricle usually does not present with murmur, but in some cases systolic murmur can be seen at the left sternal border. Pulmonary stenosis will have crescendo, decrescendo ejection systolic murmur. Persistent foramen ovale we have faint systolic murmur, and however the pulmonary arteriovenous fistula does not present with murmur. So, at this point of time, after we have done the CVS examinations, most of our differential will have some murmur, or except the hypoplastic left ventricles. Persistent foramen ovale could be the other possibilities in which faint systolic murmur is seen. Not very obvious. And the third one is the pulmonary arteriovenous fistula. These could be our three differentials that we can include after we have done the CVS examinations. And with the CVS examination, we have excluded ventricular septal defect, contraction of aorta, teratology of Fallot, total anomalous pulmonary venous drainage, pulmonary vein stenosis. These all differentials have been excluded after we have done the CVS examination. We have done the respiratory system examination, which showed shape of the chest being normal, movement of the chest is normal, trachea in the midline. On percussion, normal notes on the both sides, with sound was vascular, equal on all areas, and vocal resonance was normal on both sides. However, a bruise was heard in the interscapular region on the right side. Here, a bruise was heard. So, after a respiratory system examination, our one positive finding was the bruise. So, what differential you will consider at this point of time? What differential you will include or exclude after you have done the respiratory system examination? At this point of time, our patient had dyspnea on exertion, central cyanosis, TIA, clubbing, CVS examination being normal, and respiratory system examination showed bruise. These all were the findings in my patient after we have done the history and the examination part. So, here we can see we have that these bruise, which are the positive finding in my patient, is seen only in the total anomalous pulmonary venous fistula. Pulmonary arteriovenous fistula, in which the bruise is only seen in our differentials. Apart from it, in other differentials, these bruise will not be heard, like ventricular septal defect, contraction of aorta, teratology of Fallot, total anomalous pulmonary venous drainage, hypoplastic left ventricles, pulmonary vein stenosis, and persistent foramen ovale. Out of these all differentials, these bruise will only be heard in the pulmonary arteriovenous fistula. So, we have ruled out our two possibilities, like persistent foramen ovale, in which the bruise will not be present, and hypoplastic left ventricles, in which bruise will not be present. So, our likely possibility after we have done the history and examination is the pulmonary arteriovenous fistula. We have done the GIT examination, which was normal. So, what is your diagnosis at this point of time? Here we can see that the shortness of breath was the one positive finding in my patient. Apart from its central cyanosis and TIA, these all were seen in all my differentials, with the clubbing was also present in all my differentials. CVS examination being normal is seen only in the pulmonary arteriovenous fistula, with can also be seen in the hypoplastic left ventricles, or faint systolic murmur can be seen in persistent foramen ovale. With the bruise will only be seen with the pulmonary arteriovenous malformation. So, our all the findings can only be matched with pulmonary arteriovenous fistula. So, this could be our provisional diagnosis after we have done the history and physical examination. This was the MRI of the brain, which was done on 6th of January, which showed acute and chronic infarct in the right paraventricular region, and a lacunar infarct was also noted in the left caudate nucleus. In the right paraventricular region and in the left caudate nucleus, a lacunar infarct was noted. Stroke in young workups were all negative except the serum homocysteine level, that was 30.4. Other workups like ANA, ANCA, PTINR, protein C, protein S, antithrombin 3, factor V Leiden were negative. Lupus anticoagulant IgG and IgM were negatives. Anticardiolipin antibody like IgG and IgM were negative. These all coagulopathy workups which was done in my patient was negative, was normal. CVS 2D echo was done, which was normal. Venous Doppler of the upper and lower limbs were done, that was normal. This is the X-ray of my patient. Can you describe the findings in this X-ray? Here we can see that a nodular lesion is seen in the right middle lobe as well as in the left lower lobes. Apart from it, other patchy lesions are also seen in the left middle lobes. So, these nodular lesions in the chest X-ray, what could be our differential diagnosis that you will consider? With the patient having nodular lesions, what differential you will consider in this patient? This is a questions you can comment in the comment box. The differentials of the nodular lesions in chest X-ray. This was the one nodular lesion, this was the second and the third one that was seen in the chest X-ray. This was the CT scan which was done, that is pulmonary angiogram, which showed pulmonary arteriovenous malformation involving right lower lobe and a small in the right middle and left lower lobes. This was the DSA being done, which shows pulmonary arteriovenous malformations. And this was the post-embolizations of the AVM. Two of the feeding arteries were embolized. This is the embolus. This is the AVM in the DSA that we got. We got total of 5 AVMs in the DSA, and out of these 5 we have done the embolizations of the 2 AVMs. And here we can see this was the cyanosis that was present pre-embolizations. But post-embolization, here we can see that the cyanosis of the patient has considerably improved. You can see that this area seems to be pink as compared to this side. This is showing a bluish discolorations. But here, after the post-embolization, this area has, the cyanosis has considerably improved. With the SpO2 has improved up to 99% on room air post-embolization. This was the SpO2 when she was in ICU. This was another case. So, this was a case of pulmonary arteriovenous malformation and was managed with embolization of the AVM. These pulmonary arteriovenous malformations are abnormal communications between pulmonary arteries and veins bypassing the pulmonary capillaries. Here we can see that these are here the pulmonary arteriovenous malformations occurs, and the blood is sent from arteries to the veins bypassing these capillaries veins. Thus, here the deoxygenation of the blood does not occur, leading to the deoxygenated blood goes to the left atrium, followed by left ventricles, and then to the systemic circulations and to the brain, and where TIA can occur. Here TIA occur because of at these AVM sites embolus can be formed because of the various mechanisms which include the procoagulability states like increase in the factor 8 or decreased APT levels, endothelial injuries, chronic blood loss leading to increased platelet counts. These all can lead to platelet aggregations along with thrombus formations, and followed by the embolizations, followed by the thrombus reaches to the left atrium, from there to the left ventricle, leading to paradoxical embolism into the systemic circulations. These simple pulmonary arteriovenous malformations have one or more of the feeding arteries arising from single segmental arteries, whereas the complex AVM have multiple feeding arteries arising from more than one segmental arteries. Most AVMs are hereditary and associated with hereditary hemorrhagic telangiectasia. However, non-hereditary hemorrhagic telangiectasia associated pulmonary arteriovenous malformations have been reported, and these can be idiopathic, but secondary causes like trauma, schistosomiasis, actinomycosis, or hepatopulmonary syndrome can lead to pulmonary arteriovenous malformation. This explains the pathophysiology of a stroke in pulmonary arteriovenous malformations. Here, high fibrinogen level endothelial injuries can lead to platelet aggregations with iron deficiency anemia because of the loss of blood in hereditary hemorrhagic telangiectasia will lead to enhanced platelet aggregation, because iron deficiency will lead to enhanced platelet formations, and that platelet aggregations can occur, as well as the enhanced coagulations state because of elevated factor VIII and low APTT levels. These all will lead to pathological platelet aggregations and thrombus formations, and these thrombus can lose into the systemic circulations while reaching from the AVM to the left atria to the left ventricle, then to the systemic circulations, that is called the paradoxical embolism. These patients of pulmonary arteriovenous malformation will present with dyspnea on exertion. Apart from it, other pulmonary symptoms include chest pain, hemoptysis, hemothorax, or platypnea. It is because of right to left shunt. These pulmonary symptoms can occur. Neurological symptoms include seizures, abscess, brain abscess formations apart from TIA. Pulmonary arteriovenous malformations lead to stroke by paradoxical brain embolism. This is the mechanism of ischemic attacks, transient ischemic attacks in the patients with pulmonary AVMs. The diagnosis include transthoracic echocardiography with bubble study, and bubbles can be seen in the left side of the heart indicating right to left shunt. CT scan is the diagnostic test of choice to confirm pulmonary arteriovenous malformations because it can identify the degree and complexities of pulmonary AVMs. DSA is the next best investigations to confirm the diagnosis. The treatment include embolization of the AVMs, and this treatment should be considered in a patient with neurological complications, hypoxemia, or having the feeding arteries diameter greater than 3 mm. And in these treatment include pulmonary transcatheter embolotherapy or surgery. This percutaneous embolotherapy is of the feeding arteries of the pulmonary AVMs is the first line of therapy, and these embolizations can be done with balloons, metallic coils, or Amger vascular plugs. With these embolizations, complications can occur that include air embolism, paradoxical embolisms, spontaneous balloon deflations, pleurisy, or recanalization, as well as coil migrations. These can be the complication associated with embolization of the AVM. Recanalization account for more than 90% of the persistent AVMs after embolotherapy, and also the common mechanism of pulmonary AVM reperfusions. Surgery for the pulmonary AVMs include the patients with difficult to treat embolotherapy or refractory cases with repeated failed interventional procedures. These patients should undergo surgery, and the candidate for local excisions or lobectomy include progressive pulmonary AVM enlargement or symptomatic hypoxemia, brain abscess, diffuse lobar, segmental, or solitary large pulmonary AVM, complicated pulmonary AVMs, or life-threatening bleedings after pulmonary AVM ruptures. Video-assisted thoracic surgery should be done with idiopathic peripherally located simple pulmonary AVMs. In these cases, video-assisted thoracic surgery can be done. So, this was all about the pulmonary AVMs. To conclude with advances in catheter techniques have increased the proportion of patients who are eligible for embolotherapy. However, transcatheter embolization cannot completely replace surgical resections in all patients with pulmonary AVMs, and surgery as the choice of treatment strategy should therefore be considered in a specific cases to achieve complete recovery. Although current work in the field suggests that individualized approach is necessary for treatment of pulmonary AVMs. Thank you all for watching my lecture, and this was all about pulmonary rare case of stroke in young with the pulmonary arteriovenous malformations. Thank you all for watching my lecture.